Hi, everybody. Thank you so much for inviting me. It's been really a pleasure. I want to thank the organizers of the conference, Dr. Callahan Carew, Dawn Power, Dr. Greenfield, for inviting me, and everybody that I've met in this state. My first time has been so friendly and welcoming. Everybody at UAMS, where I spent the day yesterday showing me around. I've been really impressed by everybody I've met, and it's been a really welcoming feeling. So thank you so much. So here are some of my disclosures. I don't have any financial commercial disclosures. I did get a lot of these slides from my collaborators at CMQCC, Dr. Elliot Main and Krista Sikowski. I have two other disclosures I want to say. Number one is I definitely recognize that California is different from Arkansas, and some of what we're going to talk about might seem kind of different, right? Like the number, the size, it's different. I get that. And so I want to be really clear that what you guys are going to do in your PQC is going to be different than what we did. And there's definitely certain things that are going to have to be modified or adjusted, but hopefully that there'll be some lessons still from what we were able to accomplish that you'll be able to do here. And then the other disclosure I always say when I do these talks is I love this work. I love supporting vaginal birth because I love vaginal birth, and I'm an obstetrician, and I love going to work because every time that baby comes out of the vagina, it's like, it's a miracle, right? It's a miracle every single time. It never gets old. And it's even more of a miracle when she's been pushing for forever, or you've been watching the tracing and you're exhausted. And everyone's like, circling the drain, or all the writing's on the wall, and everybody's, murmuring. And then the baby comes out, right? And that feeling, like, that's what we're going for. So we're going to talk about numbers, and we're going to talk about, some statistics and things like that. But really, that's the feeling we're going for. And then I always say, then once you have that first vaginal birth, then you turn into the magical multip, right? And who doesn't love a multip, right? When they say a multip's on the board, you're like, oh, great, I got this. This is easy, right? So that's what we're going for. And that's why I love this work. Okay. So we are going to talk about the importance of the first cesarean, which I imagine that many of you, again, preaching to the choir, know, but just reminding some of the highlights you can take back maybe to some of the folks where you work. We're going to talk about the multifaceted approach we took in California and sort of go over all the different things that happened there. And then I'm going to bring this up a few times. I'm glad to hear it. We've already heard it many times. I have a feeling you're going to keep hearing about it throughout the day, of integrating reducing racial disparities in this particular facet of NTSV cesarean as a crucial component for this work, and really all of the quality projects we're going to work on. Okay, so I'm glad we did the first survey of who is here. That was really helpful, so I appreciate that. Quick raise of hands, you don't have to stand up. Has your hospital made any efforts so far to reduce your C-section rate? Okay, so some, but not all. All right, looks like hasn't yet been a big thing yet. That's great. Okay. And then here's a question. Does anybody here have the ability to look at your C-section rates at your unit by race and ethnicity? Okay, some hands, excellent, great. Okay, here's another question. All right, so this is sort of setting the stage, right? So you're gonna have a baby and things are good. You are low risk, right? It's your first time, the baby's head down, there's only one of them, and you're 37 weeks, okay? What is the biggest influence about whether or not you're gonna have a C-section? Is it what you want? Is it what hospital you go to? Is it how big the baby is? Is it what's going on with the heart rate during labor? Or is it your labor progress? Anybody? A, show hands. Your wishes. B, got some hands for hospital. C, the baby's weight. Okay, D, the heart rate. E, progress of labor. Okay, so it's the hospital. It is by far the hospital. And what's good, sometimes that feels kind of weird and it feels different, but what the good news about that means that this is a thing we can change. That the hospital has so much power. And unlike some of the other things that we talk about, one of the reasons I like working on this is that cardiomyopathy, that's hard to fix. Coronary artery disease, that's a medical condition. Cesarean delivery, we have a lot of control over that. And that's what's really exciting about it, because the hospitals really have a lot of control. And so, part of the reason that we know this, and I'm going to show you some of the data that confirms this, because even though we've been hearing about this, sometimes it's hard to believe, is that this is what this state, this is from 2017. This is data from then. So it's definitely old, but I put it up here to show that there's definitely a lot of variation in different states in this nation. And you know, why is that? Patients are different, but it's not just that. And also to show you that in 2017, California was 26, and so was Arkansas. So that our rates in 2017 were the same. And so I think that shows, you'll be able to see that since 2017, California's rate has gone down. And I think that that should be an inspiration that the rate in Arkansas, which again, we started at the same place, can also go down. So this is what it looked like in California. This is back in 2014. So we really started working on this in 2017. But in 2014, we looked at all the hospitals in California. And granted, there are more. I'll give you that. 251 hospitals. But you could see that 40% of them were doing it. They were at the target, the 2020 target, 23.9, which is the one we're going to talk about a lot, although now it's 23.6, but nevertheless, 60% were not, right? 60% of the hospitals were not there. And again, we look at this in all sorts of healthcare, right? When there are certain hospitals that are able to meet the target and others that are not, it makes you wonder, why is that, right? It's not just the patients. So again, if it's not the patients, then what is it? And so I'm going to talk a little bit, just a brief review of the literature, what we know about what can affect cesarean delivery rates at the system, at the unit, and at the provider level. And again, you'll notice I'm not going to really talk about the patient level because we know what risk factors are. I'm going to talk about the patient level at that in a little bit, although it's going to be different than what you might expect. And I want to say again, this is another one of my disclosures. I'm going to say it many times, right? Nobody is saying that anybody is going out doing an unnecessary cesarean on purpose, right? We don't wake up in the morning and say, I'm going to go out there and I'm going to do an unneeded major abdominal surgery on somebody who doesn't need it just for funsies, right? We don't do that. And so I think that talking about this is difficult, right? Because we have to recognize that every cesarean that we do, we're doing for a reason we think is the right choice at that time. And I don't minimize that it's a life-saving surgery, and we're so lucky to live in a place where we can do these life-saving surgeries. So I don't mean to diminish that at all, but I think as humans in society, which we are, we just have to recognize kind of all of the different factors that play into the decisions that we make every day. Okay, so again, just a brief review. System level, we have shown that if you are in a place where there is a higher differential between cesarean delivery rates payment and vaginal delivery payments, you have higher C-section rates. Again, it's not saying that somebody's saying, I want to make more money and that's why I'm doing C-sections, but these things, they influence our behavior. And showing that when you introduce a blended payment program, your rates go down. When you have states that have laws that are more favorable for midwives, you have lower C-section rates, right? So there's a lot of data out there about midwives. I'm glad some of you are here. I know that there's been progress in the state of Arkansas in terms of scope of practice. That's a good sign. That's a step in the right direction. It's been shown that states with higher malpractice premiums have higher rates, right? So all of these things influence our behaviors. What about at the unit level, right? So that's sort of at the state level. At the unit level, we know that there have been studies of culture, which we're going to talk about also a little bit, that when you have just sort of general culture, which we'll define, but also provider and nurse agreement about culture, like supporting vaginal birth is a worthwhile enterprise, your C-section rates go down. If you are at a hospital that has midwives, C-section rates are down. And if you implement a safety program, like you guys are doing, like a safety program for perinatal care, which includes, bundle elements and communication and just an overall unit culture of safety, the rates go down. It can be done. Provider level factors, right? So individuals, again, there's a lot of things that go into the decisions that we make. If you're afraid of being sued, if you've been sued, the rates are higher that you would recommend a cesarean. If you are being managed by a nurse midwife, your rates are down. If you do a lot of births, you've seen a lot of stuff, you're used to seeing tracings category 2, you know how to manage the 95% of patients who are category 2, your rates are lower. And if you, again, have favorable attitudes, which to me, again, I feel like is really the core of it. If you think that this is a worthwhile endeavor, that vaginal birth, achieving that vaginal birth is something that you want to get to, then your rates are going to be lower. And so just to show, this is why what I just sort of, you have to care. In order to care, that's one of the big steps. So why should we care? And again, a lot of this stuff, you know, particularly this importance of the first birth, right? So this is why all of these initiatives are the NTSV, the nullip term singleton vertex. It's really that first birth, because we know that most people who have a vaginal birth, they turn into the magical multip and all of their births are going to be vaginal. And we know that if they have a C-section, they're probably going to have a C-section, right? VBAC is just not taken off the way it was a while ago. And it's just, and that's what's going to happen. And we know that the more C-sections, more trouble. You've seen this too, right? Our C-section rate has been going up. And again, we are doing this not for convenience, not for expediency, because we think we are helping. We want to help babies, right? We want to help moms. We want to help babies. And again, in very individual circumstances, oftentimes we certainly are, no question. But on a population level, we have not really been able to see a decrease in CP or cerebral or seizures. And this is just a graph. It's not the full years. It's only from 85 to 2002 when the rates were going up. But the rate of cerebral palsy has not changed. We are not making a dent in that. So just important to keep that in mind. And we're going to talk about the impact that lowering the C-section rate has had on neonatal outcomes. And spoiler alert, they're better. So this is some more data on, you know, what we've been able to see nationally. This, sorry, it doesn't have a good legend, but it's the total rate, which of course includes the repeats, right, which we talked about are a tough nut to crack. And then the NTSV, that first birth low risk group. And you can see that there's really been an increase and it's been kind of steady. There's been some motion in that green line kind of going down. I think this is not the first time that this conversation has been happening. This has been something that the US has been noticing is going on and has become an important public health goal. So that's good news. This is something, again, we've seen before. Which is that severe maternal morbidity. We've been talking a lot about mortality, and Dr. Greenfield reminded us to remember the people who didn't die, right? But the ones who had the near misses, the severe maternal morbidities. And granted, a lot of these are not necessarily so severe. Sometimes you think, well, you know, her creatinine bumped a little bit, or she was just a little bit, you know, didn't have that much, wasn't really that bad. But a lot of these are, right? This is ICU, this is a blood transfusion, which, you know, might not be that big of a deal for us. But when you get a blood transfusion, right, like the narrative that those women have is, I almost died and I got a blood transfusion. They needed to give me a blood transfusion to save my life. And that's a big deal to walk around with. And so we can see that even though it's true that most of these morbidities is driven by blood transfusion, which for us is, you know, if we're lucky enough to work in a place where we have enough blood, might not be that big of a deal, but can really be a very big deal to the person who is getting it. And so again, we're going to talk about this. We have before, the disparities in our C-section rate are really striking. And I think for some folks who have been around longer than me, it wasn't always this way, right? In the 80s, the C-section rate among Black women was lower, right? And there was a big concern that we weren't doing enough, that we were underutilizing this technology in Black women. But then it changed. And now we're doing way more cesareans on Black women nationally than on white women and women of other ethnicities. And I think it's going to be really important that we look at this and we think about why this could possibly be. And I think as you see that trend that's going down, that red line there, you know, that's the non-Hispanic white women and the Hispanic white women. But for the non-Hispanic Black women, we haven't made as much of a dent. And so that's one of the things that as we roll this out, I really want all of us to be thinking about. Because, again, this is something you have seen, is that the maternal death rate is going up with these disparities that are really blatant, and also in these severe maternal morbidities, right? And again, when you see this legend is also trickier, but you could probably guess that that top line is the non-Hispanic Black women who are having increased rates of severe maternal morbidity, which we just talked about is really a big deal to the impact. And we know that while many of those maternal morbidities may be unrelated to cesarean, right? Whenever you consent someone for a C-section, what do you tell them? There's a higher risk of infection. There's a higher risk of blood transfusion, right? There's a higher risk of damage to internal organs, right? There's a higher risk for reoperation and going to the ICU and having a blood clot, right? All of those severe maternal morbidity complications are all increased with a cesarean. So while, again, looking at SMM can be this giant thing, and there's other ways to work on it, hypertension, hemorrhage, toolkits as well, which I know you guys have already done. This one, if you can reduce the number of women who are in the PACU with a C-section, then you can reduce that severe maternal morbidity. And if you can address the disparity in cesarean, then you can address the disparity in severe maternal morbidity as well. Oh, I keep these numbers. And then this thing, like, this is a big deal, right? And I will say, I know that for folks who work at the bigger hospitals who take care of the accretas, it's terrifying, right? These patients are terrifying. And for the patients, for the hospitals who don't take care of them, who are worried that they're not going to make it there in time, it's terrifying, right? And how many times have you seen a person with an accreta who's had one prior C-section, right? You think, oh my God, for something small, and you think like, what could we have done? Like, if only we knew, right? And sometimes you don't see this every day, right? I think the other part, the thing is difficult is that most of the time, thank goodness, we do a C-section, healthy mom, healthy baby, done. Great gratitude from the patients, gratitude from the family. We did a good job. And again, most of the time, absolutely we are. But a few more, she comes in for one repeat, her second, her third, and then all of a sudden it's an accreta and everything changes. And I think another thing that I've been thinking about is that, you know, the morbidity, if let's say we did it for category 2 tracing, we weren't totally sure, right? The morbidity to that baby. In that 4th C-section, who's seen a woman with an accreta deliver at 27 weeks? We just had that the other day at our hospital, 28, 32, right? What's the morbidity for that baby, right? That's prematurity. We know what that morbidity is, right? So in terms of balancing those risks, it's really important to think about those future risks as well. Okay. Again, we know this from just, you know, just in front of you, right? Most of the time the babies are fine and they go to the nursery and then they come out and everybody's fine. But it's annoying, right? Who wants to be separated from their baby? Everybody just wants to cuddle. And so when you have to take that mom and put that, separate mom and baby and put the baby in the nursery, it's hard. And we know we're not affecting the cerebral palsy rates. Okay, so cost, right? So it's kind of funny to talk about cost to a group of providers because we don't really see it, doesn't come out of our pockets. But it's important, and it can be important to the folks up there and the tables and the domes, right? And I think now, I used to talk about cost and everybody would be like, yeah, whatever. But like, we know what a global healthcare crisis is like, right? We know what shortages are like, right? When they said that there was a blood shortage, right? Like, that gives me chills, right? We could not have enough blood in this country. Like, that's a possibility. So while saving resources might not feel that important in front of the patient, you know, that you're looking at, we know we have been impacted by not having an infinite supply of resources, which luckily enough, you know, obviously, I think a lot of you who work in more rural environments have always known this, but for some of the folks who work in the bigger hospitals, it always felt like we had an infinite supply of resources, but we definitely do not, and we're recognizing that. And so it's incumbent on us to participate in reducing our use of resources. Okay, so to summarize, again, lots of variation. The good news is that means that there's an opportunity for change. Maternal complications going up, baby complications staying the same, consequences for the future, and all the cost. And again, here's the disclaimer again, cesareans are a life-saving operation, and we're not going to ever stop doing them. We just want to be thoughtful. Okay, so back to California. So this is what it looked like in 2014. Like I said, 40% of the hospitals met the target, but 60 did not. And so that offered a large opportunity for improvement. And we're going to talk about this a little bit again here and there, but risk adjustment did not reduce the variation. And this is one of my favorite slides of all time. So, because everyone will say, my hospital has the highest risk patients. I can't possibly reduce my C-section rate because my patients, have you met my patients? They are very sick, right? And they're very old and they're very heavy. And so granted, there are other ways that there are risk factors, but these are two that come up, right? Your patients are either more than 35, everybody on my unit's AMA, right? Or they're heavy, everybody on my unit has a big BMI. And this shows data from California. And so it's a little bit complicated, but the red hospitals are hospitals with a high C-section rate. And the green hospitals are hospitals with a low C-section rate. And then they're plotted on like how many heavy people and how many older people. And you can see that for every combination of age and BMI, every red hospital has a green hospital nearby. So every hospital that says the reason my C-section rates are high is because my patients are too old and too heavy has a hospital that has the same proportion of old and heavy people that has a low rate. So again, not to say that individual risk factors do not play a role, but they are definitely not the only thing. Okay, so this is what happened in California. Like I said, in 2014, we were at 26%, and so was the rest of the United States. And then we got to work. And the rate in California, it was really pretty when it doesn't always work out this way. When the graph looks like this, when the rate started going down. And yes, to be clear, the stuff we're going to talk about is the Supporting Vaginal Birth Collaborative and the statewide activities. It didn't happen until 2016, 2017. And there was already some motion happening, you can see before that. So I want to be clear that, it wasn't all from the activities I'm going to talk about, but it really capitalized on momentum and it was able to be done. And then I'm going to draw your attention again to the green line, which I'm going to say a few times, which is the severe unexpected newborn complication rate also went down, right? So that's babies with sepsis, that's babies who got cooled, who had to be transferred out. These are things we care about. This is not just a little separation of cuddling, right? This is like prolonged length of stay. This is stuff that could lead to complications in the future, went down, okay? So when you go back and people telling you it's not safe to do this, this is one of the most important things I think you can bring back to those folks. Okay, so now I'm going to tell you how it happened. And so this is a busy slide. You can't see all the words, trying to use a little implementation science to think about what we did and think about some strategies for you. That in order to make a big change, you have to include all of these domains, right? So there's the outer setting, what's the world that we're living in? What are the bigger factors that are outside of our hospitals? What are the factors that are going on inside of our hospitals, the inner setting? What are the factors that are affecting the individuals who are working at the hospital? What are the factors that are the innovation? Like, what are we trying to do? And then how are we going to implement it? And so as we go through and talk about what we did in California, I'm going to organize it this way to think about all of these different domains. And then when you are going to go back to your hospital, I want you to think about these domains as well and how you can affect each one of them. Okay, so outer setting. So granted, I will, again, be clear, this is outside of the people, most of the people, although I see some Department of Public Health people. So, most of the people in this room, this is outside. But this is very important, okay? And I'll be clear that I think in California, this was a big driver, and we have some statistical analysis to show that. But whatever you can do as citizens and as advocates and as providers to try to get this from the outside world would be a huge help. So I'm going to go through what we did here. So there was health plan and purchaser engagement. So there was a group of people that came together, they called themselves Smart Care California, and they were basically just a big consortium of purchasers and payers, and they developed engagement strategies from the insurance purchasing level. Our Covered California, our Affordable Care Act purchasing organization, made contracts with hospitals, made sure that the health plans would contract with hospitals based on their C-section rate. I'm going to show you an example of a letter. A lot of the plans added NTSV C-section rate as part of their quality incentive programs. We have a Medicaid, we call it Medi-Cal waiver program. That was a pay per performance program, which I'm going to talk about, that incentivized this as well. And all of the Medicaid MCOs had to report their rate. So this is one of the examples of the health plan involvement, right? Is that a hospital would get this letter from Health Net, which is one of our insurers, and it said that Covered California was going to require insurers to drop poorly performing hospitals, and that the members got information and said, hey, patients, why don't you consider C-section rates when you're choosing a hospital? And what was also great is they said, we know this is hard work, reach out to CMQCC to get this done. And it was very clear that the state and these groups would not have made these demands if the PQC was not there, right? Because you can't just make a mandate. We've talked about unfunded mandates. Do this, right? That doesn't work. But if we know that the policies and the support is there to get it done, and then you have the external pressure, that they work together. This was just an example of the Medicaid waiver program, which affected 21 of our 200 hospitals that were all county hospitals. And again, we had to report our data. And if we made the target, we got some money. And if we didn't, then we didn't. This just shows they actually picked a rate of 22%, which was based on the 10th percentile. They really wanted us to really reach for the stars. This is something that I think was also a big deal, and I think is maybe easier to achieve, which is public reporting, right? So the Joint Commission is now reporting hospitals with high C-section rates, more than 30. But in California, we started to just publish everybody's C-section rate. And one of the ways was in this website called Cal Hospital Compare, where you could put in your hospital, and these are our 2 UCSF hospitals, our main campus and then the county hospital, and compare what their rates are. So patients could look. And I understand that, you know, in many places, patients don't really have a choice, right? So this is not really about patients choosing a hospital based on their rate, because most patients don't have that choice based on insurance or location or whatever. But the transparency of this, of hospital administrators, of doctors, of nurses, of community organizers to be able to go on and look at what is happening in the hospitals in their community, I think is very powerful. And we even got it on Yelp. So they organized it when you would Yelp UCSF hospital, there's the C-section rate right there. There's the breastfeeding rate. And again, whether or not a patient has an opportunity in San Francisco, we have multiple hospitals, so maybe you get to choose, but it shows this is something that we care about. And again, I think having done this work, I think just getting an organization to say, we care about this, this is important, but this is one of the ways to show that this is important. We had an honor roll, and I was talking to somebody earlier, right? It's surprising how much adults, and particularly doctors, like to be recognized, right? We love certificates, right? And so it seems sort of silly, but it really works. And so getting a certificate, whenever we get this honor roll, the emails go out and the CMO, congratulations, and everybody is so happy, right? So it seems like a silly thing, but certificates, you publish it, put it on the wall, you can put it on the website. The hospitals love that stuff, right? So public reporting and making sure that everybody knows that this is something that everybody cares about. Okay, so that's kind of the outer setting. Now this is the inner setting. This is kind of what was going on. We're going to talk about the, you know, sort of in the hospital, like what can we do in the hospitals where we work on, and we're going to talk more in a couple of other places, but one of this is the data, right? Is being able to see the data. And here we had multiple opportunities also to join the collaboratives, which I know is going to be a little bit different here. Although I think what's really great is that it's being announced now. It doesn't start right away. So this is like a good time to sort of get everybody ready. You know, we were very fortunate to be able to have our data because, as you know, it's hard without public reporting. You don't know how you're doing compared with other people. You don't know what everybody else is doing. You see those state metrics, but you know, how's it going with me? And so this is the maternal data center, which I recognize is remarkable and not going to be feasible in every place. But knowing that now as an AIM state, you are reporting your data, this was one of the hugest pieces. And it's also going to get everybody in the habit of looking at data, of looking at your own data, at looking at your own rates if you don't already do it. And then also it's scary sharing it with other people, right? Transparency. It's a scary thing, but it has so much power. So just to give a little bit of a glimpse into what we are able to do in California, we submit our data to the state. It's linked with the birth certificate data, and then we're able to see it really within 45 days of the month. So I have my data at UCSF from February of 2023. Now, And then what the data center does is it compares you to the other places, right? Which is going to be hard for you guys right away because of the time that you're going to get. But what you are going to be able to do, even if you can't compare, and I think, for a certain degree, California being different, right? We had a lot of hospitals with like 9,000 deliveries, right? And that's a lot of deliveries to do chart reviews on and to be able to look at your data internally. But many of your hospitals are not that big, right? So while data collection and chart review might be a burden, the numbers are they're going to be doable. And so even if it's just this kind of stuff, which we're going to talk about in the case reviews, you're going to talk about that later and kind of going over, even knowing how many of your patients were spontaneously in labor and how many of them were induced and what your C-section rates are amongst those populations can be really helpful. Because as you're going to see with the AIM bundle and with the toolkit, the CMQCC toolkit, if you choose to use some of that, but the number of things you can do are really infinite. There are just so many different ways to attack this problem. And one of the pieces is figuring out what is going on at your individual hospital and how can you use your data to figure out what's going on and to make targeted changes. Okay, so now we're going to the resources, right? So again, this is coming from the United States, right? This is coming from our specialty societies. This is ACOG, A1, the obstetric care consensus was the first one they did, right? Where all of the leader groups in women's health and obstetrics came together and said, this is important. The safe prevention of the primary cesarean delivery is important. And the AIM resource is available. It has all of the bundle elements that you're going to go over. It has toolkits. It has more detailed. Really. And then you are always welcome to just log on to the CMQCC website, as many of you have maybe already done, and download our toolkit. It is gigantic, but it's full of stuff and it's open source and you can use it. And that's what we did. This was developed in California for our hospitals, and you'll see it really helped. And what's also cool, as that you are certainly welcome to use as well, is the implementation guide, which really gives a little bit even more detail of this is what you're supposed to do and this is how you can do it. So this is the toolkit. Like I said, it used to be, when we first started, it was 159 pages. Now it's 191. We've added a few more. So it is very big. I don't recommend that you sit down and read it first from to back, but the resources are there. And I think it's really helpful, again, if people are like, well, what are we supposed to do here? Or why is this important? It's really just like a great place to get all that information. And it's on the website. We just updated it. And again, the implementation guide, I think, can also be really helpful. So some other things that we did in terms of individuals, right? So in terms of new initiatives that we did, and we'll talk about kind of the stuff that was in that toolkit that we used for individuals. So a lot of that was just individual education for providers and nurses. We also had some patient-facing education and labor support. So patient engagement, again, I think not all of our patients have that much agency to be able to choose which hospital. And I think while patient agency is important to encourage, and we'll talk about how an engaged and informed and patient who's advocating for their own medical care often does better. I don't want to say that that's the only thing and that we're not blaming the patients for the adverse outcomes that happen to them. But again, this is a way of making sure that folks know kind of why it's important, right? And so this website came up. It's still available through CMQCC, but it's these animated features about like, why is it important? Why, if you have a choice, should you choose a vaginal birth? And again, I think there's been a lot of discussion that the C-section rate is going up because of primary elective C-section on maternal request. But that is, and that may be something that wasn't happening in the past. And there have been celebrities who have done that. But as you probably can see from your own hospitals, that number is really quite small. And so that's not the only thing we're working on when we talk about patient engagement. But we have seen, I think, on the unit that a patient who is motivated and committed to a vaginal birth is more likely to achieve it. So these are some resources. And then these are the modules. And I know today you're going to have some labor support. So this is one of the fun things that comes out of supporting vaginal birth. Again, I know a lot of the staff nurses who are here, right? That's kind of like why you got into this job too. And so being able to have tools that you can know are going to help your patients achieve a vaginal birth is really great. And again, being able to share them. So this is one of our resources, which again, is this idea that you can learn things and then teach your peers, right? So one of the fun things about this project is that it engages the whole unit, and you have some champions. I see many of you here, right? Just by being here, you are a champion. And so whatever you already knew and about that brought you to want to come here today, and what you're going to learn at the workshop later today, you're going to bring back to your hospital, and you're going to be a champion, and you're not going to hoard that information, right? You're going to share that, and you're going to get everybody else excited too. So what did we do? So we started kind of in a room like this. And we, because we had so many more hospitals, we had to do them 3 because we couldn't do all 251 in the same start. But we had cohorts, and we had a team. We had a mentor-led team. It was an OB and a nurse. And that's actually how I started with CMQCC. I was a mentor for one of these groups. And I had 6 hospitals, and they were all kind of in my geographic area in Northern California. And I had big hospitals and small and rural and urban. And we got together every month on a video call, and we talked about what we were doing. And we had to report out, and you had to send a slide. Yeah, it was accountability. What did you do this month? And sometimes people would be like, oh, we didn't do very much because somebody was on maternity leave, and then we had a staff shortage, and like it didn't always work. But you at least had to send us a slide telling us what you were doing. And then you would take your slide, and you wouldn't just share it with us, you'd share it with the rest of your unit, right? You'd share it at your staff meeting. You'd share it at the provider division meeting, so that everybody knew what was going on. You'd put it on a bulletin board, right? So these are some of in addition to the actual information that you're going to get, which it sounds like is already in the works for these collaborative learning, we would sit together on this call. This was before the pandemic, right? This is before everybody was used to Zoom. And you'd share your slides, and then one hospital would be like, we also did that. Or like, we found a great way, these are the posters we used for labor support. And this is the educational module. And we had this speaker come and talk about manual rotation. Maybe they can go to your hospital and teach your providers. And so it's really that collaborative learning that was fun and exciting and was a big piece of what we did. We had in-person visits. So I got to travel to the hospitals, and I gave grand rounds at the places. So it wasn't because the people who came to the calls, again, were the committed people, right? But and they were talking to their folks, but sometimes it's nice to have somebody from somewhere else come and talk to you like I'm doing today. And so organizing a grand rounds with an external speaker to be able to talk to everybody and explain why this is important and these are the things that you can do was helpful. We had a listserv, which I'm going to show you, which, you could share your resources. You could ask questions of the group before the meeting. If you just had little questions here and there, do you have an updated Pitocin protocol we could borrow? Like, what's your cervical ripening protocol, right? That kind of stuff can be shared. We had centralized staff, which I've already met your centralized staff and is incredible. So many resources, availability to be able to call and say, I have a question. I can't wait till the monthly meeting. And then we have these in-person kickoff and closing meetings, which, as you can see, are just a really wonderful way to get to know each other. You make connections, you get excited, and you're going to leave this meeting today energized to go back to your institutions and really start building the foundation to make the change. So this is just, again, a screenshot of our website where we were able to, once you were joined, you would get access to this. And again, just a way of sharing ideas. And if you don't have a total fancy website, just an email distribution list of who's there, and to be able to share these resources is really helpful, because I know that there's pockets. Somebody's got one thing totally dialed in and somebody's got something else. And if you can share that, it can really save a lot of time. Okay, so just going to explain a little bit about what we did, right? So we told you we had 238 hospitals, and just sort of the data of how we showed that this really helped. Because we had so many hospitals, I told you 40% of them already were doing the right thing, so we kind of left them alone. Some of them were in the Medicaid waiver program, but otherwise they were not part of our formal collaborative. And we had some hospitals who said, no, thank you, which I know is not going to happen in Arkansas, but in California they did. And then we had a bunch of rounds that they joined staggered. This is like way too many numbers. I thought about deleting this slide, but really the point is just that the hospitals that joined the collaborative versus those that didn't were the same, right? So what I'm going to show you in California is that we had success, luckily in all of our hospitals, I think a lot because of that statewide external stuff, but the hospitals that participated in the collaborative did better. So that's the lesson here, that participating in the collaborative, which you are being invited to do, made a difference. And it's not because the hospitals that participated in the collaborative were that much different. They were the same. And their patients were the same, right? So it's not like the hospitals that participated in the collaborative had all the young, healthy patients and everybody else had the older, sicker patients. They were the same. So we did this fancy analysis, a modified step wedge, just to show you sort of how we decided to do it, which is that we knew that what was cool about this is that we could compare the hospitals that joined with the hospitals that hadn't joined yet, as well as to the times before they had joined. And this shows that the rates, as you can see, for everyone, they went down. And they didn't just go down. The arrows are when we started the collaboratives. And you could see it's true, they were going down before that, but they went down more when they joined that collaborative, when they were able to get that extra support and that extra mentorship and the extra resources. And so again, coming back to the state level, right? The whole state level went from where everybody else in the United States was at 26% to 22.7%, which is well below not only 2020 goal, but 2030 of 23.6%. So again, going back to the safety issue, this is data that we wanted to publish very early. This is only from 2017. This is just the first cohort, the first two cohorts, because we knew that this is always going to be the thing you're going to hear, right? You're always going to hear, well, what about the babies, right? Is it safe? And again, it's a tricky conversation to have. And so what we're just trying to do is offer you some data to be able to talk to the people who say, I know you're not meaning to do an unnecessary cesarean. You're not meaning to hurt anybody, but we know we're not talking about you. What I'm talking about is in the state of California, they were able to lower their C-section rate and their rate of complications, all of them went down. So I've talked about the severe unexpected newborn complications, but they might say, well, what about our chorea rates are going to go up and our 3rd and 4th degree laceration rates are going to go up and transfusions and APGARs, and it didn't. None of it did, right? They stayed the same. So safely, we talk a lot about the safe prevention of cesarean birth, and the good news is you can do that. They go together. Sorry, safe prevention of the first cesarean, that supporting vaginal birth is safe, right? We have very good data. And what's even more compelling, this is a sensitivity analysis of 19 hospitals that made the biggest change, right? They were like high and they went all the way down, right? And they went from 31% to 21%, which is a pretty big change. And in those cases, you might think, well, there must have been a reason that they were doing so many, like they probably needed to do that many and it'd probably be unsafe to make such a big change so quickly. Safe. No change in all of the things that we're talking about: chorea, transfusions, unexpected complications, lacerations, even operative vaginal birth. And I think this is surprising to some people, right? Because again, one of my favorite things as an OB is to do an operative vaginal delivery when I know that I just saved that person from the OR. And not to say that that individual intervention isn't super helpful, but on a population level, you're not going to necessarily see more. You can encourage operative vaginal delivery in your unit, and you can offer more training because it's a super important tool. But that's not where you're going to see the change. It's really just in the labor dystocia, in the patients, in the confidence that if you just wait a little bit longer and you offer a little bit more support and you spend a little more time in there doing position changes, that baby's going to come out. And so this is just, again, this fancy regression just to show that we did make improvements even for the hospitals who declined to participate, but the hospitals that did participate had better outcomes. Their C-section rate was even lower. And so again, I'm hopeful that as you go back to talk to your hospitals and explain why you're joining this PQC and what the benefits are, it's that there really is data that it makes a difference. What did we do? So all of these things, right? So there was education, many things, which is just grand rounds, chalk talks, getting together, sharing this information, labor support, labor management, a dystocia checklist, inductions, patient education. And then the other thing that's here, you might not be able to see at the top of the second column, was sharing unblinded rates. Okay, of all the things that are very scary, this is one of them, right? This is very scary, but every hospital was scared. Most of the time they share them blinded first. So you just put up a graph like this in the break room, in the bathroom, on the newsletter, to see that there are some docs in your hospital who do more C-sections than others, right? Everybody knows that. And so if you just show it, that's the first way. And then a few months later, people start to be like, who am I? Where am I? Which one's me? And you start sending people their emails with the information. And then you put this up with the names. And it always feels terrifying. And then again, transparency, just shining the light is always the right thing. This is the checklist, which comes from the ACOG guidelines. This is another thing we used. And again, it's just hanging up. It's just reminding you what the criteria is. And a lot of the times it can be used before you go to the OR, although it's a little bit tricky because sometimes by the time the decision's made to go to the OR, it's been made and it's hard to kind of move away. So we try to use it before you make the decision. And it can also be used when you guys are doing your chart reviews. So again, it's not necessarily a checklist, using it as a communication tool when you do a huddle, which is one of the things we recommend, sort of huddling in the second stage after an hour or two, what's going on, where is she at? You know, what interventions have we not used? When she's stuck and there's labor dystocia and people are worried, using this on the unit to talk about what are the criteria. Okay, so some more pearls from the hospitals. Build the team before you build the plan, right? So there's so many different people that are here, but you want to go start thinking about who's going to be on your champion team. Providers, nurses, informal leaders, right? So you need your nurse leaders and your floor nurses, who I'm so excited to see. The data colleagues, the quality staff at different hospitals can be extremely useful, and particularly if you don't have the maternal data center and you're going to need to get real-time data from your own hospital, that's going to be really important. Bedside staff. And then again, community setting the stage. This is important. This is something we are working on. We're going to have scheduled meetings. So we're going to talk about this a few other times. Actually, I'm going to skip this because it comes back. So team building, right? So here's some pictures, right? These are that our hospital sent up. They did bulletin boards. They had a group. You were the champion, right? We did labor support, right? Hospitals would set up informational sessions, the peanut ball. Everybody loves a peanut ball, which again, if they say, is there data that the peanut ball in and of itself is going to single-handedly reduce your C-section rate? No. It is a way of showing that you guys care about movement in labor, supporting women during labor, and achieving vaginal birth. All of this is a part of a puzzle. Okay, this is something that some people did where they would identify them on the board. This is an NTSV patient. This is someone we're all going to be aware of, we're going to focus on, and we're going to try to help her get her vaginal birth. And when she did, they would celebrate. There's another picture here. This is a badge tag, right? So some places made a tag with the criteria. So you couldn't say you didn't know, you couldn't forget, it was always there. Celebrations. This is the most important thing, right? We just said the reason we do this is because it's fun and it feels good. And so recognizing a save. Who are the nurses and who are the doctors who achieved an NTSV birth? Who, when you guys had it, when you had a board that was no C-sections and everybody in postpartum, I don't know if you have a color coded, right? But when your postpartum board has no red on it, like, that's a bad thing. Cookies, right? Feed your staff, lots of cookies. Thank goodness now we can eat again. And really, star performers, giving awards, who was able to, just having a good time with this, making this be fun. This is, again, I think, starting to talk about the effects of the culture and making sure that everybody agrees. This is not easy to achieve necessarily. But again, it doesn't always come from the one grouchy that you have who says this is a waste of time, right? But if the rest of the unit is working on it, slowly that grouchy starts speaking less. And then I want to talk about this also, which is, again, this idea, I said that patient factors didn't play a role, right? And from a medical perspective, that's true. But this is someplace where the patient factor does play a role in what we do. And that's because every time we do a C-section, there is a measure of subjectivity, right? We always are trying to do our best. Again, nobody's trying to hurt people on purpose, but making a decision to do a C-section is subjective. We know that, right? Some people, failure to progress is called earlier. A failed induction is only, it's only when we say it's failed, right? And we know that the person in front of us, that who they are does impact our rates. And I think this is another one of my favorites, which is that physicians treating other physicians, they have a better rate, okay? So we are less likely to do a C-section if we know that mom is a physician. And what's even more compelling is that we are even less likely to do it if she's an OB or a pediatrician or a neonatologist, or she's married to an OB. So this shows that, again, it's not just the patients, right? And these are even if you have the same well-educated people of similar education, it's not just education. We know physicians are able to advocate for themselves and we do fewer cesareans on them. And that explains partly why our NTSV rates amongst the ratios are different, right? Why we are doing more C-sections on Black women, which is not to say, again, we're doing it on purpose or to hurt somebody, but there is the implicit bias. We treat people differently based on who they are when they're in labor. And we just talking about it is a hard thing to do, but that's the most first step. And maybe one of the ways is that, there's always people who say no, thank you on labor and delivery, right? They don't want to start the Pitocin. They don't want internal monitor. But this is really compelling data that Black women who say no, thank you, are more likely to feel discriminated against. And that everybody is just as equally likely to say no, thank you, right? But you might remember, sometimes do we remember those difficult patients? And do we remember the difficult patients maybe differently based on the race? And realizing this is just one of the things, okay? We can't talk about all of the things that we can do, but just recognizing that, setting up that antagonistic relationship where somebody says no, thank you, that we're able to make sure that we're not adding a layer of discrimination on top of that is perceived that then colors the rest of the medical interaction. And I think the other important thing is that while yes, nationally, we keep seeing the data that nationally the rates of C-section amongst Black women are higher. But in California, I try to be very careful in our language that we do more C-sections on Black women rather than saying that Black women have higher rates, right? Because they're not the ones doing the C-sections, we are. So I apologize if I misspoke earlier, but it's not the same everywhere, right? It's not an intrinsic thing. So there are hospitals in California. This is a histogram that shows what the rates are for white women and for Black women. And you can see that while these are all for Black women. And you can see that the range is wide and there are definitely more hospitals that have higher rates, but there are hospitals where the rates for Black women meet the target. This is not an impossible goal, right? This is not, well, we're all going to move down, but it's just impossible because Black women's rates are so much higher, it can't be done, right? When you look at individual hospitals, you look at variation, you learn that it can be done. So there are hospitals in California that have met the target for their Black patients. So we know it can be done. So strongly encourage you to review your rates by race and ethnicity. Again, if you're going to be reviewing your charts, try to use, I don't know how it's done in your hospital in terms of assigning. We try to use birth certificate because we know that's self-reported. And hopefully that's where we're all moving towards when we make these assignations, but just double checking that. And again, just transparency, just look at your own rates, post them, let people know. This is difficult to work on, but we've found that even just transparency, just showing that you have a disparity at your own hospital and that you're willing to be humble about it makes a difference. So again, we're not blaming the mom. It's not her fault. She did not do the C-section. There is a whole world that, again, I'm not going to be able to talk about in my last 3 minutes before the questions, but we can talk about as well about the Black Mamas Matter Alliance Toolkit is a wonderful resource. Really talking just in general, this is one piece of reproductive justice, which is a super important aspect of all maternal care, including labor and delivery care. But these are some things that as you're thinking about, you should take a look at and see if you can be working on as we work towards birth equity, right? And so as we're working on all of these strategies, then what I want you to do is to also consider this, right? How can we have humility. How can we consider community needs, and how can we use all of the tools in our toolbox? So the AIM equity bundle, which has been removed because it's, being worked on, and that reducing disparities and equity is not its own toolkit. It should be in every toolkit, right? But these are some of the recommendations that it had, which again, I think you can be able to work on. And it does show, as we heard earlier, that respectful care and reducing disparities is a major goal of ACOG and AIM. One of the ways particularly that we just added into the toolkit is integrating midwives, doulas, and community-based care as a way. This is a little bit of guidelines. If that seems kind of scary and foreign to the hospital, these are some suggestions. And then again, these are just some suggestions which, again, part of the reason I love this work is because the strategies for supporting vaginal birth and supporting increased birth equity, they really go hand in hand, right? It's listening. We just heard hear her, right? Making sure that we're listening. We're paying attention to social determinants of health. We're recognizing what our patients are dealing with when they come into the hospital, why, they may or may not have been able to go to all of their prenatal visits. Recognizing the mistrust. I think this is something that comes up. We talk about equity, right? You think, I am not racist. I did not cause that harm to this person, right? But what about the lifetime? Okay, what about the last time that she was here, right? It's really hard to undo that. And so you have to be humble that while you may not have ever met this patient and caused her harm and acted in a racist manner towards her, that still happened to her. And she carries that around, or she knows her sister or her friend who did. And just recognizing that it is not a criticism of you individually if this person does not trust you. Okay, there is a reason, and that's okay. We just have to sort of acknowledge that and move forward and not be defensive and take offense at it. Advocating for anti-racism trainings, encouraging doulas in your hospitals, whatever policies need to be changed, making sure that doulas don't need a certificate, right? Recognizing that requiring certificates for doulas is a burden, a financial burden, and the data doesn't show. While I encourage everyone to be certified because there's a lot of really cool information and education, that the data is just a support person in the room improves outcomes, regardless if they have a certificate. So if your patient comes and says, this is my doula, we're not going to ask for papers. We're going to just open the door wide to doulas in our healthcare team to be another person of support. And again, we're not going to be defensive that doulas are working against us, that we're, antagonistic. We're all part of the same team. Collaborating again with community groups. Again, I think remembering, somebody's told me this, right? The hospital is the community, right? Like so many of you are working in small towns and you are part of the community. Like you are the healthcare providers for this town. And so it's not the community is over there and the hospital is over here. You guys are integrated. And so I think I loved hearing about patient advisory groups as part of the PQC, and that, there's going to be hopefully some information about how to get patient advisory groups at your own hospitals if you don't already have them. And then again, just reviewing your own data by race and ethnicity is super helpful, and being transparent with it. So I don't have that much time. Everyone says, what about inductions? This is just like 2 slides to show that like inductions are neither the solution nor the problem. Like they are, you have to worry about inductions. Don't you worry. You're going to have to pay attention to inductions on your unit, but the rate of induction is not always going to correlate with your rate of C-section. And it's really on how you manage inductions. And this is just some data from California showing that the range of how many people got induced at different hospitals was different. And the C-section rates are also very different. They're not a 1-to-1 correlation. So I'll skip over that. We can do this, right? This is data. This is episiotomy data, right? Like we did that. We stopped doing routine episiotomies because they weren't helping people and they were causing a lot of pain and discomfort. It was hard in the beginning. People said, I'm not doing anything wrong. But we did it, and we can do this too. So just to summarize, this is not easy. I will be very clear. This is what I do, is I love doing this. It is not easy, and we recognize that every hospital has different personalities. They have different patients, or different communities. It is not easy, but we have seen it be successful in all sorts of places. Right? You already have the foundations of a strong team. I'm sure you can all think of people who you wish could come, but they couldn't get off service today, or they had to go somewhere else. Think of your team. There is not one single bullet. Everyone keeps asking me, in California, so what was it? Like, what was the one thing? I was like, if it was one thing, then it wouldn't be so hard, right? Like it's more than one thing. So that's okay. because it's fun to do more than one thing, because that way you're always working on something. And when you get tired of one thing, you start working on the other thing because you got a lot of things going on. So you're going to have to do that. And what's nice about that is you can engage a lot of people. This person wants to work on intermittent auscultation. Great. That's what that person's project is going to be. This person loves manual rotation. That's that person's project, right? Everybody gets a piece and everybody gets a project. Lots of easy, trying to do, again, like easy wins, trying to standardize. If you can get your checklist out, if you can start reviewing your cases, if you can make a bulletin board, great place to start. Again, it can be done. It definitely takes time. Whatever external pressures we can get, let's try to work on that and lean. Again, I think saying you're part of the AIM, you're part of the PQC, and this is what the PQC said you're supposed to do, and this is what ACOG and A1 say you're supposed to do, like that helps, right? That definitely helps. The tools are available. We've got them in California. We've got them from AIM. You're going to develop your own. You're going to share them with each other. And again, focus on equity in this and really all of your QI projects. So thank you. I stand here again as a representative of CMQCC, which is really been an incredible organization. And these are some of the faces from the first picture from the beginning and the most recent one. I have 10 minutes for questions now, and I'll be around for lunch as well, and happy to answer any questions that you guys might have. Thank you so much for inviting me.